Educational content by Dr. Mohammed Al-Nagi Mohammed. All right, let's jump right in. We're going to be talking about a really essential clinical topic, how to diagnose type 1 diabetes mellitus. And getting this diagnosis right and getting it right fast is absolutely critical for our patients. So we're going to follow a pretty clear pathway today. We'll kick things off with how the patient actually looks when they present, then we'll cover the key tests you need to order, go over the formal criteria, and then tackle that common challenge of telling type 1 from type 2. And to wrap it all up, we'll run through a couple of clinical cases to put it all into practice. Okay, first up, what does a new diagnosis of type 1 diabetes actually look like when they walk into your clinic or the emergency department? Well, the presentation is usually pretty acute, and often it looks like a serious metabolic emergency. A whole lot of patients show up for the first time already in diabetic ketoacidosis, or DKA. You've got to be looking for those classic osmotic symptoms. That's the polyuria, where they're urinating constantly, and polydipsia, that intense, unquenchable thirst. This is all happening because the high blood sugar is literally pulling water out of the body's cells, leading to some pretty significant dehydration. And since the body is starved of glucose, it gets desperate and starts breaking down fat, which produces ketones. This leads to a metabolic acidosis, and the body tries to fix it with these deep, rapid breaths. That's what we call Kussmaul respiration. And those ketones, they're what cause that really distinct acetone or pear drop smell on the breath, and can even cause some pretty severe abdominal pain. So your clinical suspicion is high. Now what? Let's move on to the essential investigations you need to confirm what's going on. What are the very first tests you should be reaching for? It really starts with the basics. A simple urine dipstick is a crucial first step, and you can bet it'll be positive for both glucose and ketones in this situation. At the same time, you absolutely need to get a blood sample for serum glucose. That gives you the hard number, the objective measure of hyperglycemia that you need for the diagnosis. Now, you might be wondering about other tests. What about C-peptide? Well, C-peptide is released right alongside insulin. So in type 1, where the body's own insulin production is wiped out, C-peptide levels are going to be super low or even undetectable. It's a key differentiator. And HbA1c, for an acute diagnosis, it's actually not that helpful. Just remember, HbA1c reflects the average glucose over about 3 months. Since type 1 comes on so fast, we're talking days to weeks, the HbA1c just hasn't had time to climb. So the really crucial step to confirm that it's type 1 is to show that it's an autoimmune disease. And we do that by testing for autoantibodies. This table shows you the main players. Just look at the high prevalence of anti-GAD and ICA. We're talking around 80% of patients. And for the really little kids, check out IAA. Insulin autoantibodies are positive in more than 90% of cases. A positive test for any of these is incredibly strong evidence that you're dealing with an autoimmune type 1 process. Okay, so we've got our clinical picture, we have our first lab results back. Now let's get into the formal criteria we use to make that definitive diagnosis official. Listen up, because this is a really important point for your clinical practice, a truly high-yield fact. If your patient has symptoms, the polyuria, the polydipsia, the weight loss, then you only need one blood glucose reading that's over the threshold to make the diagnosis. You do not need to wait for a second test. So what's that threshold? The first one is for fasting plasma glucose. A value of 7.0 millimoles per liter or higher is diagnostic. And for a random plasma glucose, and that just means a measurement taken any time of day, it doesn't matter when they last ate, the diagnostic cutoff is 11.1 millimoles per liter or greater. But what if you find a high glucose by accident, say in a patient who has no symptoms at all? Well, here the rule changes. To make sure you don't misdiagnose someone based on, say, a temporary stress hyperglycemia, the criteria have to be met on 2 separate occasions before you can officially confirm a diagnosis of diabetes. All right, let's get into what is probably the most common diagnostic headache, telling the difference between type 1 and the much, much more common type 2 diabetes. Some cases are a slam dunk, but there's a huge gray area where it's really easy to get caught out. So this table kind of lays out the classic textbook differences, right? Type 1 is usually in younger people, comes on fast, they've lost weight, and you see ketonuria. Type 2 is classically in older, overweight folks with a much slower onset. But, and this is a really crucial point, we are seeing type 1 in older adults and type 2 in younger obese patients all the time now. So you just can't rely on age and BMI alone anymore. The NICE guidelines actually give us a very handy set of clinical clues to look for. If your patient has hyperglycemia and has one or more of these features, ketosis, they're losing weight fast, they're under 50 with a normal BMI, or they have a personal or family history of other autoimmune diseases, you have to have a really high index of suspicion for type 1 diabetes. And this brings us to a real game-changing recommendation from NICE. When should you actually order those C-peptide and autoantibody tests? Well, NICE says to think about it when the picture's a bit atypical. For example, a patient who's over 50 or has a BMI over 25, but you still think it might be type 1. Basically, think of these tests as your problem solvers. They're the tools that cut right through that diagnostic uncertainty. Right, time to put all of this together. Let's test out our diagnostic pathway with a couple of quick-fire clinical scenarios. Let's see how this all works in the real world. Okay, here's your first patient. A teenager comes in with classic symptoms. The urine dip is positive for ketones and glucose, and their random glucose is way up at 14.
So, just take a second here. Based on everything we've talked about, what are you thinking? What's the diagnosis?
Yep, the diagnosis here is type 1 diabetes, no question about it. Young age, weight loss, ketonuria, and a random glucose well above that 11.1 cutoff. This is as classic as it gets. You don't need antibodies or C-peptide here. The priority is to get treatment started immediately. All right, now for a trickier one. We've got a 38-year-old man. He's obese, he's complaining of polyuria, and his random glucose is 12.5. Okay, so we know he has diabetes, right? The random glucose confirms that. But which type is it? That's the real question. What's our next move? So in this case, the picture is really mixed. He's in that middle age group, and his obesity is a huge risk factor for type 2. But we absolutely cannot rule out type 1. This is the perfect example of an atypical case where NICE would tell you to go ahead and measure C-peptide and autoantibodies. This is how you stop a misdiagnosis in its tracks and make sure he gets the right management plan from day one. And that really leaves us with this final thought to chew on. As the lines between the typical presentations of type 1 and type 2 diabetes just keep getting blurrier, using these tools like antibody and C-peptide testing is more critical than ever. You know, getting the diagnosis right from the get-go isn't just an academic exercise. It's everything. It's the difference between the right treatment and the wrong one, right from the very beginning.